Hello, my name is Michael Wallace. I'm the current editor-in-chief of Gastrointestinal Endoscopy, and it's my pleasure to be here today with Dr. Ali Abbas from the University of South Florida. And we're going to talk about his recently accepted paper on endoscopic management of postcholecystectomy biliary leaks. Tell us a little bit about yourself, Dr. Abbas.
All right, so I'm a third-year fellow in the University of South Florida in Tampa, and in a few weeks I will be moving to Boston to start advanced and bariatric endoscopy training with at Brigham and Women's Hospital, Harvard Medical School. It's my pleasure to be here. Thanks for Dr. Wallace and the GIE for inviting me for this interview. My paper is about endoscopic management of postcholecystectomy biliary leaks, when and how, using a national database.
Good. Well, I'm glad to see you're going to a fantastic place. I'm quite familiar. I did my training at the Brigham and came to Florida, and you did your training in Florida and going to the Brigham. So, tell us a little bit about biliary leaks. How common are they? How much of an issue is it? Why did you choose this topic?
So, biliary leak is a drastic complication of a very common procedure, which is cholecystectomy. Fortunately, it's not that common. It's about 0.3 to 0.9%. So if you are doing about 750,000 cholecystectomies annually in the United States, you would expect 5,000 to 7,000 biliary leak cases per year. And endoscopic management is the first-line therapy for that, and it's safe and effective. But there's inconsistency in the literature about the timing of this procedure, whether it's an emergency or more of a planned procedure, and also the nature of endoscopic management. In terms of the timing, there's only one paper by Dr. Adler who pulled the University of Utah and Thomas Jefferson's cases and concluded that it doesn't matter if you did it within 24 hours or next day or after 2 days. In terms of management, there's a lot of small single-center studies that suggested either a sphincterotomy or stent or combination or nasobiliary. So it's kind of all over the place, and it's evident in the current ASGE guidelines, who pretty much left it up to the endoscopist what to choose to reduce the transpapillary pressure gradient. In terms of the European Society of Gastrointestinal Endoscopy, they advocated for stent only, to avoid the long-term effect of sphincterotomy in predominantly young population. So as you can see, there's not much consensus about the best way of managing it. So we decided to look into a national database and see what is the outcomes.
So just to sort of distill that down, what do you think were the major unanswered questions that you wanted to try to address?
So primarily is the timing. Is it something that you have to do overnight? Is something you have to do over the weekend? Which come first? Is there a biloma that has to be drained, or the ERCP with the stent placement has to come first? And in terms of that, these questions, does it affect the outcomes? And also, in terms of the best management, if you only have to do a sphincterotomy, why putting a stent and then having the patient to come back for stent removal? You can finish the procedure in one setting, and additionally, the long-term consequences of sphincterotomy, is it worth it? You can do a stent only and maintain the patency of the papilla. So all of these questions and also the variability. When I discuss that with my colleagues, it's all over the place. There's no single way of dealing with this issue, and all of them pretty much are highly effective. But you would always strive for the best in terms of the efficacy and the least invasiveness for the patient.
So I think all of us have been in the situation where you get a call on a Saturday afternoon. The surgeon said, my cholecystectomy yesterday is having pain and we see a leak. We'd like you to come in right now and do something about it. So you really focused on the timing. Should we do it right away that day? Should we let the patient be stabilized for a day or two, or can we do it electively? Some of the other things that I saw in your study were, what are the outcomes in rural areas versus urban or teaching hospital environments? Is this something that really should be in a referral center?
Yes, definitely. I noticed that the major hospitals in urban areas have better outcomes for managing these biliary leaks. And primarily, I think it's related to having a multidisciplinary teams, including surgeons and radiology and gastroenterologists, advanced gastroenterologists who are familiar with these situations. Definitely, I would, based on what I saw, I would recommend, referring these leaks to a tertiary center.
So one of the problems about doing research in something like this, it's a relatively uncommon event. So no one hospital gets a large number of cases, and certainly doing a randomized trial is challenging. Tell us about the study design. How did you try to study this relatively uncommon event?
Well, large databases are ideal for uncommon procedures or uncommon diseases. So, and the fact that this condition is primarily getting treated in patients. So the NIS, the Nationwide Inpatient Sample, is the largest inpatient sample sampling of U.S. data. Basically, we identified everyone who had cholecystectomy as a primary procedure. Then we identified people who had biliary leaks. And then we included the subset of people who had ERCP management for these biliary leaks. And we tracked the timing of the ERCP in relation to the timing of the biliary injury, which is the cholecystectomy timing. And the nice thing about the NIS database is providing the date or the day of the procedure in relation to the admission, so you can do an interval and then you classify them into 24 hours, 1 to 2 days, and above 2 days, very easily. And in addition to that, we can identify the therapeutic interventions by ICD-9 codes and classify them to sphincterotomy only, stent only, combination therapy. And also we track the outcomes. In-hospital mortality is provided in the database. And we identified also a composite outcome. We called it post-ERCP adverse events, which is a marker for post-ERCP, post-endoscopic intervention, poor clinical outcomes. So if the patients required invasive cardiovascular monitoring or inotrope infusion or hemodialysis or non-operative mechanical ventilation, that's a marker of major organ failure or a marker of sepsis. If it occurred after the endoscopy, meaning that the outcome of the therapy is poor, that's a marker for the post-operative outcome. If it occurred before the endoscopy, that's a marker of presentation severity. Most people have cholecystitis or sepsis related to that, so we try to identify also a marker for severity, and we use this composite outcome depending on the relationship to the ERCP in both ways. We also tracked the failure of endoscopic therapy, and we defined that as the need for surgical biliary intervention or radiology intervention to the biliary system after the ERCP. So if the leak was persistent, it makes sense they will go and operate on it. So these are the primary 3 outcomes that we identified. We also identified variables related to comorbidities, age, teaching status of the hospital, and also the geographic location of the hospital.
So with regard to really the 2 key issues, the first one being the timing. Should you do it right away? Should you stabilize the patient for a day or 2? Should you do it electively a few days later? What was your main finding?
So after including 1,000 patients, which is the largest set of patients who have been investigated for this issue, the time did not matter at all. So basically within 24 hours had about 10% post-operative complication rate, post-ERCP complication rate, and then the same for the 1 to 2 days and above 2 days. So there was no evidence that doing it earlier will have better outcome. But this is a retrospective analysis, so I will come to that later into this meeting. So the other finding is the mortality rate showed a U-shaped curve. Within 24 hours had about 5%. The 1 to 2 days have 0% mortality rate. And the above 2 days have 2%. And when you identify the case severity, you will find a similar trend. And being that within 24 hours had higher severity, and the middle group had lower, and then another higher peak for the above 2 days. So it's clearly the decision to make an ERCP is not random, obviously. It's a very careful clinical decision that takes into account the availability of the staff, availability of the facility, and also obviously the patient condition. So in terms of the timing, we did not find any evidence of doing an earlier one will get a better outcome. Otherwise, you will see another trend. You will see an ascending trend, or you're not going to see a U-shaped trend. The later, the worse. That's what you expect. In terms of the failure, didn't matter actually. In terms of the therapeutic intervention, it looks like the stent monotherapy is as good as the combination therapy. In terms of the failure rate, about 3 to 4%, which is pretty low failure rate. Sphincterotomy monotherapy had a failure rate of 11%. So it's still not bad, but it's definitely lower than the stent monotherapy or sphincterotomy. But sometimes you have to do a sphincterotomy for stone extraction, which is the case in about 28% of the cases. Primarily, these biliary leaks can be secondary to a retained stone, which is something that you will have to do a sphincterotomy for. So by default, you're going to do a combination therapy.
So it sounds like the two major findings were, first, in terms of timing, there was no major difference in terms of adverse event rate if you did it immediately within 24 hours, if you did it urgently within 1 to 2 days, or electively beyond 3 days.
Correct.
And then secondly, that stent therapy with or without sphincterotomy was clearly associated with better outcomes than sphincterotomy alone.
Correct. Correct.
So in terms of the limitations, obviously this is a retrospective look at a large database. We know we can't prove causation, that waiting a day or two to do your therapy it causes the better outcome. What are the other possibilities that could explain this, for example, the U-shaped curve?
Correct. So that's an inherent limitation of any retrospective analysis, and especially when you're examining the temporal relationship of a certain intervention with the outcome. If you don't have a randomization element in the design, you're not going to be able to, for sure, saying that the timing is, within 24 hours doesn't matter, but it's impossible to do randomization with these cases. So the best quality of evidence will come from multi-center studies and national databases, because there's no single center that is going to be able to reach statistical significance in terms of the numbers. So what we try to do is to identify the severity of the cases. So that is a factor in the multivariate analysis, and hopefully that will limit the effect of the severity as a predictor of poor outcome. Good. And with that is included, still the timing did not make a lot of difference.
Good. So just to wrap up here, we want to give our readers and other colleagues some take-home points from this study.
So as I mentioned, probably doing the ERCP next work day is as good or probably better than doing it within 24 hours. Based on this study and Dr. Adler's study, there's no benefit, and perhaps there's increased mortality, but you have to take it with a retrospective design context. So doing it next day after adequate stabilization, if there's a biloma, you have to drain it, resuscitation, antibiotic therapy, and then once the facility is ready. And also, by the way, I forgot to mention that the weekend showed worse outcome. Doing an ERCP during a weekend had 29% post-operative adverse events compared to doing it in the weekday, which is 8%, so which is the baseline basically. So that's another reflection of evidence that it's what's surrounding the procedure is what's kind of the main factors in determining the outcomes rather than the timing itself. But again, this is a retrospective data. Second point is probably doing a stent alone is as good as doing combination therapy, but we cannot control for the grade of the leak. Some papers suggested that for high grade you would consider combination therapy. And also I would think based on this paper and whatever published before, it's reasonable for low grades without stone retention to do a stent only and have it out without compromising the patency of the papilla. So that's basically the main point.
I think our readers will be very happy to hear that there's no major advantage of coming in the middle of the night or coming in on the weekend to do an emergent case. These are obviously complex cases, so your data provides some supporting evidence to let things cool off, do it under controlled circumstances, do it in the best possible facilities. Good. I want to thank you, Dr. Abbas, for this very nice paper, and taking the time to educate our readers and audiences
My pleasure
about
always.
this.
My pleasure always.
Thank you.